Namaskar, Hare Krishna. We have a very interesting case who got admitted with us as a case of altered sensorium under the evaluation. This lady, a young patient who came to us, she's 29 years old, and on the basis of the CSF examination, we were suspecting this case to be a case of tubercular meningitis, query with the possibility of bacterial meningitis. She started getting better in between after starting the ATT. Obviously, this clinical diagnosis which we were having on the basis of the CSF examination, we also got the MRI contrast brain done, which was suggestive of multiple tuberculoma in the brain, which were highly suggestive of that we are dealing with the differential of TBM. Now this patient was improving. Here things become more confusing and interesting. This patient on ATT was getting better in terms of the GCS, in terms of overall the sensorium, ABPU scaling and all. But in the last 24 hours, there is suddenly a change in her baseline sensorium level. She started having a new onset fever spike, and with the fever, she has gone down in terms of the GCS. The previous GCS was around E4, B3 and M4, which is now almost like 7 or 8 by 50. In a due course of the time, if she continues to be like so, she will be requiring AV protection as well. Now the question comes, which I want to ask first maybe Dr. Ankit, that what could be the reason why the patient has gone down steeply, who is otherwise was getting better in terms of the ATT treatment, and where the diagnosis was very clear with us, we are dealing with the tubercular meningitis. What could be the possible differentials which you can think about in this case?
Very nicely elaborated the case. We are dealing with a case of tubercular meningitis. So when we discovered the routine investigation, patient discovered to be a hyponatremia.
So one is that maybe the patient is having a hyponatremia.
So maybe symptomatic hyponatremia. That's why maybe the GCS is on the lower side.
But why the patient is developing hyponatremia, Dr. Ankit? We deal with so many patients. Why a patient who is having a TBM we should be having a suspicion of hyponatremia? This is the question comes.
So
and anybody can answer. If Aarti and Dr. Datta, you feel that if you have something a better answer, please volunteer.
Maybe just because of that, TB meningitis is most common. The thing is SIADH.
So that's a very important thing. I think we already raised this discussion in the morning course, that if you have a CNS infection, they particularly have predisposition for hyponatremia, and very commonly they have two common differential. One is SIDH, and the second is cerebral soft-Blechdruck syndrome. What could be the other reasons which has led to this change in the sensorium? Because sodium is 127, Dr. Ankit, and 127 is not so less. So if you see the ranges between 130 is generally patients, they come to us and they are by and large they are clinically asymptomatic. So 127 is not such something, because if you see the change in the sensorium, generally the literature supports if the sodium is less than 120, we get worried in terms of coma, in terms of change in the sensorium. So these numbers, they are pretty good.
As we are dealing in the case of meningitis, like it's infection. So probably this could be the possibility of vasculitis. If it is a vasculitis, there is high chanceability of inflammation is getting flare up.
Very nice.
So because of the flare up of the infection and the inflammation, there is possibility of some hypercoagulation or infarct could develop in such patients, because sudden drop in sensorium, sudden drop in GCS, it can lead to infection related
very important
infarct
differential.
cases.
I think this is very important, because I agree with you, Dr. Ankit. If you are having a localized milieu which is hyperinflammatory, which happens with TBM,
Yes.
because the local milieu, the CSF is hyperinflammatory. In those kind of things, they develop vasculitis. It's the inflammation.
Yes.
And when you have a hyperinflammatory milieu, the vessels they get inflamed, and because your vessels get inflamed, it leads to the vasculitis based infarct.
Yes.
And which is a very important differential. So what do you think, Dr. Datta, in case if you're having a suspicion of that maybe my patient is having an infarct, which the patient has developed now, how do you approach? What should be the next step? How will you plan that? What should we do for this case?
I think we should go for a repeat scan, MRI
Excellent.
scan. And after the scan, we can think of probably getting a repeat LP done.
Very nice. So that's why, all this kind of cases that Dr. Datta, Dr. Ankit has elaborated, whenever you find that the patient's sensorium has got changed from the baseline to 2-3 things they happen into the picture.
Yes.
One, as you said, we must look for the dyslipidemia, especially the sodium, which affect the sensorium, which we have already seen in this case, which may be the contributory factor, but may not be the standalone factor which led to this, the grievous fall in the sensorium.
Multitude of reasons.
Yes, multitude of reasons. Maybe a contributory, but not maybe the standalone reason. Second, Dr. Datta said, in fact, you only said that vasculitis-based infarct, which could be one possible. Anything else which you're thinking?
Hydrocephalus.
Hydrocephalus, okay. So why you think hydrocephalus could be a one differential in this case? What is making you to think about hydrocephalus?
Because patient is on steroid with the AKT, so there may be the chances of the increase of hydrocephalus.
Okay, so let me just reframe and paraphrase what you have said. So if your patient is having a TBM, they form a lot of exudate in the CSF. And because they are having a lot of inflammation which generates exudates, they have a tendency to block the flow of the CSF, which happens through the ventricles. Then they go to the foramen of, foramen of Buschicki and Megendie and, all those kind of tracts which are there for a normal CSF flow pattern to happen. So in case if there is an obstruction which happen at the level of, because they cannot flow through the ventricle, then this is how it can happen with them. So that is one very, very important. I think this is a very important point that we must rule out communicating or obstructive hydrocephalus in this case. So would you like to go for any specific investigation in this case?
For this, we'll do MRI with
Again,
contrast.
very nice. So I think as Dr. Datta has said, as you have said, two important indication why scans are important in them, right? Anything else, Dr. Ankit?
Other than this, there is a possibility of, because we have discovered this hyponatremia, there could be a possibility of cerebral salt wasting as well.
Very nice. So how will you think about CSW, cerebral salt wasting syndrome? How do they present?
We will do the investigation of serum sodium osmolarity and urine sodium osmolarity.
Which is going to be less in them.
Which is-
So I think the most important thing which you should do, if your patient is having a signs of hypovolemia, which means you measure the CVP in them, they are hypovolemic on obvious examination. In those kind of cases, you must suspect the patient to be as a CSW. Versus a patient where you're talking about SIDH, where majority of the time they are euvolemic.
Yes.
Right?
Yeah.
Now, I would like to ask maybe Asha and Ansari ji and Ravinder and what is her name, beta? Sweetie. So Sweetie, अगर एक ऐसा पेशेंट है आशा रविंदर, पहले तो मैं आपसे पूछना चाहूँगा, अगर कोई एक ऐसा पेशेंट है जिसका सेंसोरियम एकदम डाउन हो जाता है, तो आपकी नर्सिंग केयर में क्या चेंज आता है ऐसे केसेस में? आपको क्या लगता है?
हम उसे कैसे ट्रीट करेंगे सर?
थोड़ा सा लाउडली आशा.
सर जब पेशेंट ड्राउजी होता है तो सबसे पहले हमें जीसीएस देखना चाहिए.
वेरी गुड. सो जीसीएस सबसे इम्पोर्टेंट पॉइंट है, हमें जीसीएस देखना है. और जीसीएस देखना है क्योंकि जीसीएस अगर डाउन हुआ तो ऐसे पेशेंट एस्पिरेट कर सकता है. एक तो ये वाला पार्ट हो गया. और क्या कर सकते हैं आशा आपके नर्सिंग केयर के हिसाब से?
नर्सिंग केयर के हिसाब से
रविंदर आप
ERP मैनेजमेंट करना सर.
एवे मैनेजमेंट. सो मे बी इंटरमिटेंट सक्शनिंग हैज टू बी डन.
Suctioning.
अगर जीसीएस 7 से कम जा रहा है,
प्रॉपर
8
पोजीशन से.
हाँ, so maybe a recovery position if the patient allows. अगर recovery position नहीं है तो maybe a semi-proper position ताकि वो regurgitation कम हो. ठीक है. And third आपने कहा कि अगर intermittent oral suctioning, provided that this suctioning is not leading to trauma and the bleeding. So that is important point. और कुछ जो आपको इसके बारे में समझ में आता है ऐसे patients में?
वाइटल
So vital monitoring. So vital monitoring क्योंकि क्यों patient का GC down हो रहा है? वो सबसे important चीज़ है. Generally जब blood sugar, very good.
बीपी,
blood sugar, BP. So basically hypoxia, hypercapnia, euglycemia, normotension. There should not be any hypotension. There should not be any hypothermia. There should not be any H plus signs. There should not be hypercapnic.
Yes.
So all this kind of a baseline things you take into account. So or kuch anything which you want to add, Aarti and Dr.
Pupil
Datta?
monitoring.
Pupils,
monitoring.
so pupils assessment. Why you think pupil assessment they are important?
Because
So nursing care में pupil assessment is very important. But why you think pupil assessment is important? Anybody who would like to volunteer?
Because as we are suspecting, it could be some infarct could be there because of the vasculitis. So because of the infarct, there could be a rise in the blood.
So infarct can lead to a damage, maybe a particular segment, and that can affect your intracranial
Intracranial
pressures.
pressures.
So that is one point. The reason why we do it, because these are one of the lateralizing signs which tend to happen. So lateralizing signs means which needs immediate intervention, and one of the lateralizing sign is if you assess the CNS examination, they come in a one basket now. Lateralizing signs. Either the patient is having a tonic-clonic posturing of any specific limb, asymmetrical posturing, or the pupils, they change in the size. And these kind of cases, they must be evaluated for raised ICP or any intracranial complication, which could be a infarct, or which could be, vasogenic edema, or it could be any hemorrhage, which can happen with them. Now, this is one important point. We are suspecting this case to be a possible vasculitic infarct, but there are no lateralizing sign, if you see, because pupils are okay, and there's no asymmetric posturing of any specific side, right? So that goes against the possibility of infarct, right? Any other thing which you think could be a possible reason for the patient? She also had a new onset fever spike.
Yes.
So what could be
Maybe
other
a
reason?
secondary infection.
Yes, that is very important. What happens, Aarti, that patient has a primary reason, which is a TBM for the admission. But there could be a secondary nosocomial reason which has led to the flaring up of sepsis or infection, which has led to the deterioration of the patient. Now, what are the common infection in them? Maybe the patient has a central venous catheter which is causing CRBSI. Maybe patient has a Foley's catheter which is causing COT. Or maybe the patient is having a microaspiration which is leading to microaspiration syndrome, right? So all these kind of common things, they also are responsible for the deterioration in the patient. Apart from this, would you like to repeat this CSF examination in them? And if yes, then why? Dr. Dutta, what do you think?
CSF examination would definitely be recommended to repeat again, because
Can you be loud? Can you be loud?
that can make us diagnose as a multi-drug resistant tuberculosis.
Very important. Because what happens, you will find that one subset of population, they become resistant. So if you are dealing with a multi-drug resistant CNS tuberculosis, that is a big disaster. And that is why whenever there is any acute change in the sensorium, you must do a CSF examination, repeat the assessment for them, apart from your radiological studies. So both have to be taken. So clinically there is a change, radiologically there has to be change, biochemically there has to be change. You put them together in one basket and reach for a conclusion. So for that reason, we have to get a brain scans, contrast MRI, to look out for, as Dr. Ankit said, vasculitis-based infarct. As Dr. Datta said, that in case if your patient is having any other issues like hydrocephalus, which you also said. Third, you will have to do the CSF examination to exclude the possibility of MDR, the tuberculosis. How you are going to exclude? Obviously, you have to measure the CSF sugar, CSF biochemistry, and the CSF has to be sent for gene expert analysis, which is going to tell you whether there is rifampicin resistance or not, right? Anything else which you
Blood culture.
Blood culture is important, and you have to do your sepsis surveillance. How old the catheter is? Foley's, how much old the Foley's catheter is?
5 days.
5 days. So
4-5
4-5 days doesn't seem to be like a risk factor, but you should consider all these things, right? So patient is on monocyte vancomycin. Maybe if you don't find anything, so I would suggest you get a repeat procalcitonin also done. If you find procalcitonin is on the high side, then maybe you will have to isolate for gram-negative sepsis, which is likely to happen in the setting where the patient is staying in the ICU for a long number of days. She has Foley's catheter, and any catheter which is beyond 48 to 72 hours is a risk factor for nosocomial sepsis. So maybe in that situation, you may require to change the Foley's catheter as well. So with this, I would like to bring conclusion that these kind of cases, they're very common. Tubercular meningitis, these are one of the commonest cases which you're going to witness in your ICU, especially in Indian setup. And you will find them that one subset they improve, one subset doesn't improve, one subset they improve and then they deteriorate. So the patient who get better, definitely we are happy for them. But the patient who doesn't get better, obviously they have certain complications like hydrocephalus is there, infarcts are there. But the patient who are improving and then deproving or falling into the trend, they are the one which becomes the biggest concern for us, because they are the one where we are likely to avoid secondary brain injury in case if you intervene them early, right? With this, I would be happy in case if you have any questions, you can post it onto the YouTube, and we are there with you to answer all the questions and all the suggestions, including if you have any criticism which you want to share with us. Thank you very much.